Thank you. So the title of my talk is Cathedral and Bazaar, and I did borrow that, but I referenced it. It's taken from a BMJ article, and some of you in the audience are the authors. So, Cathedral and Bazaar, grade as a scaffold for implicit knowledge, and I'm doing this in collaboration with Samantha and CauseHealth. And so here's the cathedral and the bazaar, and in this context, to me the cathedral structure represents linear explicit cues and rational choices, and the bazaar structure symbolizes implicit judgment and the logic of care. And then I have a Trish quote, in contrast to the world of rational choices, the logic of care is unbounded, nonlinear, and unpredictable. It's about everything that happens to a person as they live with illness. And then I have a Poloni quote, we can know more than we can tell. Tacit contributions are key to bridging the gap between explicit cues and implicit judgment. So I'm just setting the stage here for my view of tacit and codified knowledge. To me, they are complementary. They're not competitive. And there's Wittgenstein is known for this sentence. Whatever explicit guidelines are created to guide judgments, the specification for how to correctly follow them remains implicit, either by environmental conditioning or innate composition. And this is the rest is from an excellent paper I don't have time to discuss, and so I paraphrase it. Codified knowledge can increase learning by structuring tacit knowledge practices. It can stimulate and structure medical decision-making by adding to theories, for example, that emphasize the tacit component, or that assume clinical resistance to codified systems without considering associated organizational dynamics. Codified knowledge also can support but not determine clinical judgment. Tacit knowledge is essential to produce and interpret encoded knowledge and to balance its significance against other information about the patient in making decisions about patient care. And the outline for my talk, I'm going to first review the guideline development process using a grade framework, and I'm going to gloss over a lot since lots of it was covered in the morning. I'm going to discuss the 3 types of grade guideline recommendations. There's strong and weak recommendations, and then there's and recently there's guidance for good practice statements. And that is especially interpreted in the context of explicit-implicit judgments. And then I'm going to propose how the epistemology of evidence may be echoed through grade and EBM. So here's an example of a guideline. Glaucoma treatment guidelines, methods and key to ratings. You have sign and grade. And here you have sign. You have the typical hierarchy, meta-analysis, RCTs on top, case reports, case series on bottom. And here's the grade guideline development framework. So you see the panel in the middle. They start with PICO, as Beth discussed earlier. And then once the outcome across the studies are individually assessed using sign, then the body of evidence for each outcome is assessed using grade. And this is the criteria that they use: risk of bias, inconsistency, indirectness, imprecision, and publication bias. And so the body of evidence is graded downward for those qualities. And then large effect, dose response, opposing bias, and confounders, the body of evidence is graded upwards. And as an epidemiologist, I think that really covers all bases. So I'm very happy with that aspect of grade. Then there's sort of a newer part of grade. It's called from evidence to recommendation. So how do you create a guideline based on the evidence once it's rated? And so the components to this part are quality of evidence, balance of benefits and harms, values and preferences, feasibility, equity, and acceptability, and resource use. And so to me, that covers the bases also. And I think that although they're almost like just checking a box, which has been criticized because these things can, balancing benefits and harms can be the major part of your guideline if it's important. But here it's just checking a box. But if you have issues with balance and harms, it really affects the strength of your recommendation. And there's your guideline. Okay. So here's the paper that discusses the grade strong and weak recommendations. So they can be either strong or weak. So strong recommendation is used when the desirable effects clearly outweigh the undesirable effects, or vice versa. And the words that are used are recommends. So the panel can recommend that blah, blah, blah should blah, 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 or should not. Weak or discretionary recommendations are used when the trade-offs are less certain, either because of low-quality evidence or because evidence suggests that desirable and undesirable effects are closely balanced. And then the terminology that GRADE likes to use is suggests for the recommendation. Okay, strong recommendations. Clinicians can apply them to all or nearly all patients in all or almost all circumstances without reviewing any underlying evidence or detailed discussion with patients. So that is about as explicit as you can get. In these situations, the certainty of evidence is typically high or moderate, but it can also be low, and I think I have an example for a low one, a strong recommendation with low evidence. There's very high confidence that consequences are either desirable or undesirable, and there's no, it's very clear. All patient-relevant outcomes are included, so there's no variability in the outcomes. It's so obvious what they are for patients, and no patient will have any outlying outcomes that they're interested in. And then cost is clearly justified. And there are some idiosyncratic exceptions to these strong recommendations. For example, aspirin is strongly recommended for myocardial infarction, but it can't be used to treat patients with aspirin allergies. So that's pretty obvious. Here's an example of a strong recommendation based on low certainty of evidence. Here, the 89 guidelines recommended against the use of anticoagulants in pregnant women. There's very strong evidence of efficacy for anticoagulants, but with respect to harms in this population, there's low or very low certainty of evidence. So therefore, there's a strong recommendation against the intervention with possible greater harm. So there's different components that can get you to the conclusion of a strong recommendation. So weak discretionary recommendations. To use weak recommendations, clinicians will need to consider key factors driving strength of recommendations. So is the underlying evidence the reason why it's weak? Are the benefit and harms too equally balanced that you don't even know if it's going to be useful? Or is there a large variability in patient values and preferences? And if this is so all weak recommendations are asked to go to the shared decision making, and that's a key part. And clinicians may present potential benefits and harms of the intervention to patients and families in order to help patients make decisions consistent with both the best evidence available and patient values and preferences. And so this underlying evidence serves as a scaffold for implicit judgments during shared decision making. And here's a great study. I really like this field, the social science field. It's use of implicit persuasion in decision making about adjuvant cancer treatment, a potential barrier to shared decision making. So here the context was breast cancer. And part of the guideline was treatment and care should take into account patients' needs and preferences. Patients with early or locally advanced breast cancer should have the opportunity to make informed decisions about their care and treatment in partnership with their healthcare professionals. So that's all nice and good. But then the results of this study, oncologists frequently use implicit persuasion, steering patients towards the treatment option that they think is in the patient's best interest. Expected treatment benefit does not always seem to be the driving force behind implicit persuasion. Awareness of one's use of these steering behaviors during decision-making is a first step to help overcome the performance gap between advocating and implementing shared decision-making. And just some details for the study. So they have many types of implicit persuasion, but they bucketed them in these 4 categories. There's unbalanced presentation of benefits and side effects. There is presenting treatment recommendations as authorized decisions. There's creating the illusion of decisional control, and persuading patients using clinical experience. And then this figure shows the range of implicit persuasion behaviors per oncologist. So each bar represents one oncologist, and so you see, the variability and quite a few. The y-axis shows quite a few behaviors, implicit behaviors being used. Okay, so that's the end of that. So the next form of guideline that GRADE has given guidance for are good practice statements. And first they published this article, Guideline Panels Should Not Grade Good Practice Statements. And then within a year, they published this one, Guideline Panels Should Seldom Make Good Practice Statements. So what are they anyway? They're recommendations derived from indirect evidence or comparisons along the causal pathway that demonstrate a net benefit. A good practice statement should be clearly distinguished from a recommendation formulated using GRADE. So here's an example of one. For patients with congenital adrenal hyperplasia, we recommend monitoring patients for signs of glucocorticoid excess. And this is from the Endocrine Society. So, is it plausible that without the statement, clinicians will fail to monitor signs of glucocorticoid excess? Is it an implicit assumption based on clinical experience? If so, then you don't need the statement. So basically, these publications are advocating a reduction in guidelines or statements if there's no need for them. And they're being quite explicit about that. And some reasons to not make good practice statements. Is the unstated alternative absurd or clearly not conforming to ethical norms? Is high certainty indirect evidence along the causal pathway that is onerous to formally assess and doesn't need to be graded? This is kind of similar, I think, to mind lines, which are derived from previous experience with similar problems. So what GRADE is doing is it's taking published good practice statements and saying a lot of them, most of them, are actually, in my words, mind lines. So you don't need any public statement for those. And these good practice statements, you don't need RCTs, you don't need formal studies to have high confidence in evidence quality and effect estimates. It's just implicitly understood. Oh, that came out pretty clear. So here's a table. I just tried to summarize some stuff. This is all still from those two papers. And for strong recommendations, GRADE did some studies looking at usage. And for the Endocrine Society, 43 out of 121 strong recommendations that were based on low or very low certainty of evidence were actually good practice statements by GRADE criteria. So that's 36%. And if we follow what the guidance for good practice statements, they shouldn't even exist. Similarly, 18% of strong recommendations were actually good practice statements in WHO guidelines. So that's 29 out of 160. And, okay, that third one is too hard. Okay, so weak recommendations, categories. So this is the category where the vast majority of recommendations lie. And the American College of Chest Physicians, for example, they have antithrombotic guidelines, and 2/3 out of the 1,600 of their recommendations were weak. So that's really the world of where you want to engage patient values and preferences with weakly recommended guidelines. And then the good practice statements is just kind of the inverse of the strong recommendations. They're overused. Try not to make them. It's the same data from the strong blocks. In the explicit, implicit context, strong recommendations, a lot of them are explicit. There's no need for review or shared decision making. Applies to all or nearly all circumstances. There's idiosyncratic exceptions. Discordant recommendations where evidence does not warrant strength of recommendation should be ungraded good practice statements, or not statements at all. Or they may be implicit heuristics, which I don't want to use that word after Mike Kelly said that heuristics are a crappy thing. So they may be mind lines with no need for explicit guidelines. And in for the weak recommendations, explicit. You use the best evidence formulated through the whole GRADE process as a scaffold to frame the transparency of recommendation development, informing clinical judgment, and facilitating the shared decision-making. And this enables an expression of implicit clinical judgment and patient values, and it can help identify and potentially reduce implicit persuasion. And then good practice statements, implicit, they're implicit, no need to create most of them. Often implicit mind lines in clinical practice that need not be explicitly recommended. Yeah. Okay. So grade, cathedral, and bizarre. I guess what my point here is, I think most people just categorize grade as this linear cathedral thing, and to a large extent it is. It's limited by language. Whenever you're being explicit, you're talking. That's a linear process. And then the whole concept of healthcare is quite a bizarre. But I think the grade framework looks like a bizarre. And grade it serves as explicit mapping for this bizarre. And so it's just a map. Okay, where did grade come from? This is the philosophy part. Where did grade come from? So I have some quotes from famous people. A wise man proportions his belief to the evidence. That's David Hume. The mind, if it will proceed rationally, ought to examine all the grounds of probability and see how they make more or less for or against any proposition before it assents to or dissents from it. So you got kind of the hierarchy. That's John Locke. And then every degree of evidence perceived by the mind produces a proportioned degree of assent or belief. Probable reasoning, and this is Thomas Reid, probable reasoning, according to Reid, has degrees of evidence, ranging from the very least to the greatest, which we call certainty. So we have proportions and degrees of certainty, and we're assessing all the grounds of probability resulting in assent or dissent. And in this summary of one-liners, and that encapsulates some of Grade's foundational framework and implicit normativity. Okay, so when I started this whole philosophy of evidence and engaged Samantha to help me, the first thing I went to was, what is evidence? In philosophy, how do you define it? There's absolutely no definition. But what they do instead, this Thomas Kelly, he's at Stanford, I think, he offers 4 roles that evidence plays. So if you see evidence in action, you kind of get a better picture of perhaps what it is. And so, this took me an hour to understand. So I don't expect you to understand it now, but I have to go through it. So first, evidence is that which justifies belief. So, in a EBM context, degrees of certainty of evidence is proportional to Grade's recommendations, which we can call beliefs. 2, rational thinkers respect their evidence. Clinicians represent a community of rational thinkers who use evidence to make judgments about patients and the appropriateness of interventions. And then 3, you have evidence as a guide to truth. So that's the most explicit form of evidence. And an example is signs and symptoms are used as evidence to guide clinicians to correct diagnoses. For example, Koplik spots are evidence for the presence of measles. And even if your mind doesn't implicitly know, doesn't recognize it as a sign of measles, it still does. It doesn't need your implicit recognition. It is a sign of measles. And then last, evidence is a neutral arbiter. So Grade is an example of how evidence can be used as a neutral arbiter insofar as it provides a system for assessing evidence and creating guidelines. So to summarize these 4, in roles 1, 2, and 4, tacit mental processes are integral to the role of evidence, whereas in role 3, evidence can exist regardless of whether it is recognized by a mental process. So these varying contributions of explicit and implicit judgments across these roles is a source of tension in epistemology. That's why there's no definition. Okay. So how to unify these explicit-implicit tensions of 4 roles of evidence. So there's only one person who's attempted this, and that's Reid, Thomas Reid, and only Patrick Risu, who is a contemporary philosopher at University of Victoria, has interpreted his work this way. So Reid has a common sense approach to evidence by making the role of evidence to be whatever it is that enables evidence. So with that definition, all 4 roles of evidence are completely satisfied. While evidentness exists either externally or internally, The link between explicit evidence and evidentness depends on implicit psychological factors. So ultimately, it's your mind that goes, wow, I get it, right? It's a psychological thing. Diverse things can enable evidentness, observations, experience, propositions, and the results of experiments. Not all these things can be shared or made public, and what makes something evidence can be quite tacit as well. In the context of EBM, quality of evidence, collective mind lines and heuristics, patient values and preferences all enable evidentness. The divergent concepts of evidence and internal aspect of evidence may also explain why guideline panel members, clinicians, patients, despite assessing the same evidence, often draw different conclusions. And my conclusions, grade is only relevant for clinical decisions that require formal assessment of best evidence. So that's the world of grade. So if you're criticizing grade because it's I don't know, not doing implicit stuff, it's because it's not part of what it is. It's not part of its framework. Although it indirectly does tell you what is implicit by saying that's not a guideline, that's not a recommendation, that you should know on your own. So it definitely has that implicit aspect. Some strong recommendations and most good practice statements shouldn't be graded because certainty is already implicitly there without requiring formal research, and they belong to the world of mind lines and not guidelines. Grade weak recommendations serve as an explicit scaffolding that helps produce implicit persuasion that occurs during shared decision making. The implicit normativity that conceptualized grade reflects the measured epistemological relationship between evidence and certainty, and unresolved epistemological discourse surrounding evidence impacts evidence-based medicine. It's in the title, so how could it not? Ultimately, evidence is whatever helps to trigger evidentness. That's an internal epiphany brought on by explicit, implicit, tacit judgments that vary across communities and with individuals. And that's it. Thank you.